I'm curious, was he one of the people that kind of spurred that interest in this, health economics, research based? Like what, I know you obviously your background was in the statistical, analysis realm, but what spurred that for you to say like, I'm really going to because it's not like you do this thing on the side, right? You spearhead this and you're pushing it forward for essentially across the board in spine. And I'm curious what spearheaded that
thanks for the question. So, I came at it initially from this idea of anyone that has a background in statistics loves the idea of having a data set they can play with. So that was how it started. But then I was shocked to find out when I was in like the middle of my residency that spine surgery, as an example, is a field where we don't regularly measure the outcomes of what we do. And in most fields, I'm talking about outside healthcare, whatever you do in life, there's this essential sort of aspect of it where you measure so that you can improve. And the fact that wasn't being done regularly in the spine world was shocking.
Yeah.
And that even the definition of what success is wasn't really established was exciting, because now it's like, oh, okay, so that's a little concerning that this hasn't been happening all this time. But on the flip side, we can help define what that success looks like. How do we make sense of all these metrics that we're finally starting to collect and translate into something that is digestible to patients, to employers, to payers, and everything? But Clint and his partner, Matt McGirt, I think really, amongst others in this sort of small sort of vanguard, really sort of dropped the gauntlet, or threw down the gauntlet and said, we need to measure things that are important to patients, and then start to understand how to pick treatment options or to pick the patients that are ideal for certain treatments based on the analytics we can do on these metrics. So that was just like it was almost a no-brainer for me to be able to jump in and help do some of the early work around, for example, like if my family member needed to get a TLIF, and I'm in clinic with them talking to a surgeon, the kind of questions that I would ask, knowing how the sausage is made, is like, all right, what do you think the chance is that she's going to be able to return to work in 6 months, or that she's going to get a pseudoarthrosis, or that she's going to have to go to rehab? I know now, being in practice for a few years, that we sort of give these sort of vague answers like 80% or 15%, or it's not data driven at all. And to be able, for a surgeon to be able to say, hey, look, we have this predictive model. Here's an iPad app. We've plugged in the specific information about your unique characteristics and the specific surgery that we're thinking about for you and your particular diagnosis. And here are some personalized probabilities of both positive and negative outcomes for you. You tell us which of these outcomes on either side, positive or negative, are most meaningful and important to you. And then we can have a shared decision-making process about whether this is the right thing for you or not. I think we all want that in any aspect of care. And the fact that didn't exist and that we could help build some of the models to power some of that stuff was just fun. It was like a fun thing to be a part of. And so that's kind of how I got into sort of the outcomes side of things initially.